I had mentioned Merrill Steel back in 2016 when I joined them. They're still at their same premiums that they were in 2016. And 60 and 40 a month. Healthcare is actually not expensive if you do it right, right? Health insurance is really expensive because you have a lot of hands in that cookie jar. Healthcare is very reasonable. So companies and even employees, they go into Best Buy for a reason. We all know how to shop for value. We don't walk into a car lot and say, give me the black truck. It looks really nice. I don't care what the price is. Send me the bill later. No one ever does this. So why are employers doing this with their health plans? So are you getting value? Are you spending $5,000 on an MRI that you could get for $400 in a newer machine? Are you spending $100,000 for a hip replacement that you can get for 20? This sounds crazy, right? And then people are like, that's too good to believe. Well, maybe, but it is real. It's not exaggerating. That is the actual facts of where we are with today's healthcare.
Welcome, everyone, to this edition of the Take Charge podcast. I'm Dan Hinmon. I'm co-host of the podcast, and I'm thrilled today to be here, of course, with our host, Aase, and especially delighted to have Matt Ohrt with us. Matt's a leader and a innovator in this whole direct patient care market. He leads, he speaks, he writes, he trains, and so we're really excited to have him with us today. Matt was with us in a previous episode where we talked more about his history and some of the ways he got involved with direct patient care and the benefit to corporations and his influence and this movement, really a movement that's happening in not only in the Midwest, but throughout the nation. So it's great to have you back again, Matt.
Yeah,
Great.
thanks for having me. I'm certainly looking forward to the discussion.
Yeah, well, I just kind of wanted to pick up with what we ended with last time and just talking about this different model of this different way of doing healthcare that kind of breaks apart the monopolies of the big insurance carriers and reassembles them with better parts. And I thought it was enlightening for me when you talked about direct primary care being sort of the foundation, the kind of the indispensable cornerstone of a plan like this. In fact, I think when we talked, almost 2 years ago now, you said it was because you were looking for a direct primary care clinic in Minnesota because you had some folks on one of your plans that needed to have that access. And you said, I won't do a plan without direct primary care. It's just non-negotiable there. So I'd love to have you talk a little bit about how that works, but then also what are some of the other elements that need to be in place to have more than just the primary care, but to have this full scope type of solution.
Yeah, I'm still saying that phrase today. That is when we go to a new area, that's the very first search, is that if we don't have direct primary care, it's not a stubbornness, it's just that it won't work, right? It's just I'm not going to set somebody up for failure or go down a path. There's probably, you could say, two big reasons why DPC is the heartbeat of a direct care model. And there's many pieces, and I think a lot of people dabble with maybe 2 or 3 or 4 or 5 pieces. What I've tended to do, like with the self-fund health plan and now the new Rise Up health plan that's launching in Texas in the next few months, is try to put like every piece that we feel is needed, right? As few pieces and partners as possible, but right, everything. We're trying to cover all bases and all angles. But the DPC is significant. Number one, we're bringing primary care back to the way it was something like 30, 35 years ago. Now with some new technology and learnings and research, but the concept of relationship has been removed from this, right? The 7-minute pinball machine that we go to, and the docs are just frustrated. It's not that the docs are less skilled or less caring, right? Imagine if you're a mechanic and I'll give you a choice. You have 3,000 cars to keep on the road, and you get 7 minutes with each car, and every 7 minutes you're going to get a new car, or you have 500 cars to keep on the road, and I'm going to give you 30 or 60 minutes to treat those. And of course it goes further. You don't have to be a car guy like me who seems to use a car example and everything. But right, we talk about relationship. We talk about accessibility. If I've only got 500 patients, give or take, something like 400 to 800 is probably the range, but 500 is maybe the average. Now I'm accessible on my cell phone. So text me. Who says this, right? The doc says, text me if you want, or email me, or call me. I can actually talk with you. Imagine that, because I'm only seeing maybe something like 6 to 10 patients a day. So just the pure time leads to a lot of the things that direct primary care can do. Chronic condition management. We can manage things like early onset of diabetes. We can manage weight management, high blood pressure, things like that. We have time. So we have time. We can actually talk about it. Just, I would say rushed care is not good care. The second one is something I realized all these were kind of aha moments along this journey, right? All these things I share today, like they're just matter of fact, they were all kind of like, aha, this day, aha. So I realized, right? So we know in the hospitals that they have to refer to themselves. In fact, the doctors will get in pretty big trouble if they don't, because that's their money, especially if you've created primary care as your referral machine. They need to refer inside to that expensive specialty care. They say that the most expensive thing in healthcare is the primary care doctor's pen, who they're referring to. So the primary care serves as a funnel, really as a collecting the patients and then distributing them to the expensive care. Now we actually model that as well. We use direct primary care as the funnel, except we just want to get them to the best care. We're not against anyone. If it happens to be at the hospital, that's fine. It's not usually. Or the best care might be at a direct specialty care. So patients listen to the white coat, right? They trust that white coat with authority. There's plenty of research projects that show the white coat carries authority, but they also have that relationship with their doctor, or at least a mild relationship in the hospital. They trust that doctor and they're going to go where the doctor recommends. So in DPC, we say, like within our plan design, we might say you can go to the hospital. Now there's a deductible attached because it costs more, but the care is questionable. It's kind of a hit and miss quality. Or you can go over here and I know the exact price and the exact quality. And so we give patients a choice, but we're really trying to steer them to value. Just as we shop in all other things, we shop for value, right? We naturally assess quality, accessibility, and cost when we buy a car, when we buy groceries. And the same should be for healthcare, but the market's been hijacked. So we're just bringing it back to free market style.
So what are some of the other elements? What are the pieces, the big cost drivers in a typical health plan?
The biggest cost driver is direct specialty care. And you could throw a couple others in there, maybe in that big cost bucket, but direct specialty care, right? So oncology is very expensive, cardiology is very expensive, and so forth. So we're surgeries, orthopedic surgeries can add up, especially in volume. We're also looking at things like specialty drugs, which can be just out of control in terms of cost. And so we can do a lot of things to interrupt those costs. And then stop loss, which is actually considered a fixed cost in a self-funded employer model, can be very expensive as well. Those are probably the top three that come to mind.
So how does that stop loss work? I mean, I think people people express a lot of concern about, especially with smaller employers, to be able to do, self-funded something other than the fully insured plans. It's like, well, what if my employees have a really bad year, really bad claims? So how does stop loss interact with that?
Yeah. So there's kind of maybe two significant or key ways to do self-funding. If you're a smaller employer, and very generically something like 50 to 150 employees, that's plenty of exceptions to that. But if the cash flow is lower, generally it's smaller, and you want a more consistent payment, level funding or level loading can be a good option, because you're paying a set amount each month, and it's the same, and stop loss is a little more involved. And then depending on the stop loss, not all level funded plans are the same, but you want to pick one that's employer owned. There's a lot of brokerage houses and different things where they're pulling money out of these things. They're actually using them just to get clients, and stop loss agreements along with captives, which I can cover in a second. But stop loss, and I meant that employer owned, I meant that for captives. My brain was running ahead, so forgive me. But the stop loss is really key. So level funding for smaller, and then for bigger, traditional stop loss. It's really ultimately it's protecting employers from extreme cost. It's saying, what happens if I get $1 million claim? Well, stop loss is going to kick in on those. So stop loss is going to protect the employer from getting burned. And then just a quick point to add on the captives. Captives are another layer, and captives use stop loss as well, but they can be very advantageous, because then if you get in a pool of employers who are trying to do things with healthcare, a captive can be good because they can also refund some of the money. So like level funding, they can refund. So if things go well in terms of claims management, the overriding theme on self-funding is that this year's claims are next year's premium increase, right? So if you're trying to do one thing in managing your self-funded health plan, it's to manage your claims costs, because we don't want to get into next year's enrollment meeting and they're all horrible, right? 10%, 20%, 30%, 40%. That's ultimately what we're trying to prevent. I had mentioned Merrill Steel back in 2016 when I joined them. They're still at their same premiums that they were in 2016, 160 and 40 a month.
Wow.
Yeah, I know.
Amazing stuff. Really amazing stuff. So there's a new documentary that we're going to be showing here in southern Minnesota in a couple of locations in Austin and Rochester on September 4th and September 11th, called It's Not Personal, It's Just Healthcare. And I know that Dr. Keith Smith has been involved along with Jay Kempton, in producing that. What's the message of that documentary, and what can you tell us about that?
Yeah, it's been a little while since I've seen it, so I think it's not fresh, but I would say in general, right? I mean, just this recognition, I think we've seen the reputation of big insurance in America with the CEO assassination, and America's response to that was like 75% of one of the studies was a laughing emoji over a murder, right? But this shows how Americans feel about big insurance and what's happening, because denying a claim can be the death or suffering of my family member, right? This is pretty personal. This isn't just Wall Street or big business, but it's really about the fleecing of America through hidden money and hidden practices. And many of the things that the healthcare industry does would be illegal or absolutely not allowed in other industries. Ultimately, though, right, as part of the FMMA, we think the solution is that we need a free market. The way that you provide a free market is you don't fight the beast, you just don't feed the beast. You need to feed someone else that is offering a better service. And right now in healthcare, because of these restrictive networks, we're not able to do that, right? We're not able to shop where we want. We go into Best Buy, right? Why is it called Best Buy? Because you have other options. They're trying to say we have the Best Buy. But in healthcare, you go into your network and they say, oh, you had a bad experience. We really don't care because insurance is our customer, not you. And by the way, we're going to send you to collections if you don't pay this exorbitant bill really fast. And we'll see you next time. Have a nice day. Like no other industry works like that. You lose business when you don't take care of your folks and you're hurting them instead of helping them, but not in a monopoly. They got you.
Lee, how would folks find out about these screening times? When and where and how they would register, whatever they need to do?
Right. So if they go to our website, helpcare.health, we have a blog post that talks about the September 4th and September 11th screenings of this documentary in Austin and in Rochester. And it is our chapter, our Minnesota chapter of the Free Market Medical Association is sponsoring it. And we've got some of our members that are helping to fund and promote this. But it's intended for business owners, for HR folks, company leaders, for public sector employers, leaders, as well as for medical professionals who are interested in unplugging from the matrix, so to speak, and looking at how the system could be different. So we're getting popcorn and movie snacks and everything like that, and it'll be a good time and just have some good discussion and a chance to hopefully open some people's eyes about opportunities that are out there. Matt, last time we talked about your first book, which was, Save Your Company, Don't Feed the Beast, the Employer Healthcare Success Formula. Did I get it right?
That's right.
Pretty close, right? Yeah, okay.
You nailed it.
You've got another book that's just out, just brand new. It's written at a little different level. Tell us about that and what that's all about.
Yeah. A lot of what we do, we talked about the 4-hour joke. A lot of what we do is education, right? And I think that's what that documentary, right? It opens eyes, people that don't know all we know yet. But we were there one day. We were there before I was there. But yeah, it's called Good Care Feels Different, a story about direct primary care, DPC, first page, DPC for you and me. This is actually, it looks like a children's book, but it's not a children's book, right? It's just got colorful pictures and short. You can read this. I should time it. I would guess around 10 minutes. This isn't meant to be the same as like this kind of book, right? Now, a lot of people hand this out. I have people buy boxes at a time and they hand it out because that 4 hour thing, right? Here, employer, read this. Okay, this will give you the full story. But here's the 10-minute version, but it's just about DPC. This is actually, we designed this and wrote this with the intent to actually hand out. And I think we make on the Amazon version, I think it's already 25 copies. So this one sold 25 copies on Amazon last month. It's about one a day. I've sold a way more on the outside of Amazon. It's over 6,000. This sold 25 copies already on Amazon last month. This one's passing it big time, but it's meant to be purchased in 10 or 20 or 50 for DPCs to hand out to employers or advisors. But you don't read this and put it on the shelf as much, right? Because I suppose you could, but it's really you'd have no need to keep it. It's that simple, but it's meant to say, here, what's DPC? Here, 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 and really just blast this direct care movement open. And so we're pretty excited about it. We think it's cute and funny. And by the time you get done reading it, though, you should have a pretty good understanding of why DPC, why everyone's talking about DPC.
So you were talking a little bit earlier about that the system is really messed up. I mean, and maybe not redeemable, just in the way that it is right now because of so many stakeholders with so many tentacles into it. And yet you seem like a pretty cheerful guy overall. And I think the thing that I'd like to have us sort of, as we move toward closing this, talk about is just the opportunity that this is, that, that there really is a chance for employers to significantly improve what they're able to provide for their employees, for employees and patients to get that care that feels different, that you talked about. And then also for practitioners, for doctors, for nurses, nurse practitioners, PAs, surgeons, to get out of a system that's kind of ground them down. So talk a little bit about that and how you see that and your mission with this.
I think when I get up every day, I mean, one of the things, I think it's great to run a business. It's great to run a successful business, but and I have to do that too. But what's on my mind, especially, is until American healthcare is fixed, or you could take it state by state, then I'm really not satisfied. It doesn't do any good to run a successful business in healthcare, but have the whole thing crumble around you, right? So I think it takes kind of a selfless approach of all of us. Like this book, for instance. I'm making $1.50 per book on Amazon every time it sells, and it sells for $15. So you're probably asking, what am I going to do with all the money? But actually 75 cents of that will go to Dr. Shane Purcell. So it's actually so we can sell this in bulk for $7, $8, or $9 or $10, right? But I could come at it as a goal to try to make as much as I could, which is nice. I have a family to feed, but I think we all have to think big picture at the same time. So I would say, for employers, this is getting kind of real, right? So I can speak from employers' shoes. I'll always tell you what I don't know, and which is a lot, but I'll tell you what I do know. I do know employers. I worked for employers for almost 25 years. And I think it sounds almost silly, but employers need to treat health care or their health plan like they do every other area of the business. These are skills they already have. You've probably heard about my vacuum story, right? Where I was having to fill out all this purchasing paperwork for a $400 vacuum. And it was taking hours. And I realized that I had just signed the stop loss agreement for Merrill Steel that morning. Now, this is every company. This wasn't just Merrill Steel. It's just an example. But I signed the stop loss agreement for $700,000 that morning. And all I needed was a quick nod from the CFO. I didn't need anything from the CEO or president or owners. And so somehow within companies, these are viewed as benefits, but they're not viewed, and they're viewed as health insurance or insurance, but they're not. And don't you dare touch them, because recruiting is already really hard and you're going to lessen our benefits. What's interesting is we start to dig in and we start to say, let's purchase health care, not health insurance. Healthcare is actually not expensive if you do it right? Health insurance is really expensive because you have a lot of hands in that cookie jar. Healthcare is very reasonable. So companies and even employees, they go into Best Buy for a reason. We all know how to shop for value. We don't walk into a car lot and say, give me the black truck. It looks really nice. I don't care what the price is. Send me the bill later. No one ever does this. So why are employers doing this with their health plans? So are you getting value? Are you spending $5,000 on an MRI that you could get for $400 in a newer machine? Are you spending $100,000 for a hip replacement that you can get for 20? This sounds crazy, right? And then people are, that's too good to believe. Well, maybe, but it is real. It's not exaggerating. That is the actual facts of where we are with today's healthcare.
Well, and when they say it's always darkest just before the dawn, right? I mean, that's the old saying, and that it does provide an opportunity for people to do things in a different way. This isn't global health reform that fixes everything all at once, and as you said, going through the government to do that probably isn't going to be the direction that's going to get you there anyway. But by making it possible for people in communities to take action, change their community and change what's happening in locally for them. That's the really invigorating thing, I think, from my perspective.
Yeah, as many have called it, Dave Chase, localizing healthcare, right? Community-owned healthcare plans or health plans, right? We can take a small region or section of a state or a town and look at what's a model that works there, and then just amplify that. But we know that even you can even listen to the United Healthcare calls and investor calls, and they're really concerned. They're not concerned about patient health. They're not concerned about American communities. They're concerned about dollars, which is an important piece, but it's the only piece to them. So if you want to see your community crash, keep buying big health insurance and keep doing everything that we've been doing just like we have. Or if you want to do different, there are actually proven ways out there now with many doctors who care through DPC and many doctors who care through DSC. And as soon as the payers, which is the employers, wake up and realize they're throwing their money away and it's being shipped off to Wall Street, nothing wrong with Wall Street. I'm a capitalist, but it's being shipped off in a very uncaring way, and it's crashing your community, then maybe we'll change. But it is going to take the employers to get in this game.
And the great thing about it, direct patient care, is that it benefits really everybody on the right side, right? Like in the last podcast, Matt did a really good job of outlining who are the winners and who are the losers, right, in the healthcare. And the losers right now are the patients and the doctors, because the other side's up making all the money and making all the rules. So here we have a system where doctors have a chance to get off the hamster wheel and provide the kind of care that they were trained to provide and want to provide. We have a system where patients, through employers, can get quality care and get it with less money, particularly the employers in that case, as far as the money goes. And then thirdly, the patients get this opportunity to have these 30, 60-minute visits with physicians so that chronic conditions can be evaluated and they can really get that kind of care that they actually want. So win-win-win if we can move it to that kind of a practice.
Yeah, Keith Smith talks a lot about mutually beneficial relationships in my book, and ongoing, I talk about win-wins. That's right. And today we have a win-lose. We have the industry winning, and then ironically, the physicians within the hospitals and the buyers losing. And I just don't know of any single relationship that's win-lose that sustains. So if you're driving toward the cliff and you're not pumping the brakes or turning the wheel, I think you're headed for trouble, right? So we've got to find a win-win relationship, and then we can go forward.
Yeah. Matt, well said.
Very good. Well, just one more thing. I don't know whether we'll keep this in or not, but I just wanted to raise this issue because we talked about how, big government solutions, big national legislation isn't necessarily the answer. On the other hand, there was recently some legislation that relates to this that can be pretty significant, I think. I just want to get your take on how the so-called One Big Beautiful Bill Act making direct primary care eligible for just a reimbursement, how that might affect this whole movement.
Yeah, I think, it's my view that government probably has caused more damage than it has helped. But ultimately, I see the government, and probably with good intent, maybe they got tricked by the industry or something. So maybe not the ultimate solution, but certainly they have an impact. And government's role ultimately, to me, is to make sure of a free market. We know free markets that are regulated properly are how America has thrived. Right. So they failed to really regulate. They're failing today to regulate this new bill. I think is probably a huge step for DPC. The big winner in that is DPC, and anyone who uses DPC. Within a traditional self-funded health plan, it's probably not all that beneficial because we're already blending in the DPC cost with it. And HSAs don't tend to work in that if you want to steer to specialty care, because you can't do that net free, at least without moving some money around and taking some extra steps that are legal, but a lot of administrative work. But DPC is to me, this is going to blow up the DPC movement, which is really big for America, because if you have a health savings account that's a tax advantage, but then you have to use it for things that are exorbitantly expensive, it's not that great of a deal, right? Now we can use it. Now members can use it for DPC. So I would say look out in the next couple of years. We've already seen DPC explode. I think that bill is going to make it go that much more. It's not the full solution, but it was just like CAA of 2021, I think it was enacted, and it kicked in, every consecutive year thereafter. That helped us as well. So there are definitely legislative efforts that help us. They're not the solution, but they enable us to do the solutions.
Well, I think the big thing is that, as you said, if you have your employer-based plans that are the 50 to 150 kind of employee or lives that are covered, yeah, you can factor in direct primary care as part of that solution. But what I think that this bill does is it enables people who work for smaller employers, or people who maybe have their health plan through one of the exchanges, where they aren't able to, they don't have the buying power to necessarily make those kind of changes like you'd see with some of these employers, but it kind of democratizes a little bit. And from our perspective, we are not an on-site clinic. We are near site, and we're open to the community. So we have retail members, and we have corporate members, and we have members who are part of a health plan. And so I think that's where it's going to be pretty significant for the folks that we see.
Yeah, I would say look out, because anybody with an HSA now can use that, right? Employers can even fund the HSA if they want. I would say
Right.
look out. That's a good foundational component for what we're all trying to do.
Starting January 1st.
Yeah, can't wait.
Very good. All right. Well, thanks so much, Matt. We're delighted to be able to connect with you again. And again, welcome to your new role as the Executive Director for the Free Market Medical Association, as the chapter co-leader for Minnesota. I look forward to working with you in that role and seeing what we can do to continue to bring this revolution forward.
Yeah. Yeah, absolutely. Thank you guys for doing this podcast. Every bit of education helps, and we just need to keep pushing, right? I always say we're here anyway. So you can watch the problems go by, or you can do something about them. But thank you for doing your part.
Thanks for joining us. If you enjoyed this episode, be sure to leave a comment or a review, and to subscribe on Spotify, Apple Podcasts, or on YouTube. And also to share Take Charge with HELPcare with your friends and on your social media channels. At HELPcare, our passion is helping people take charge of their health and their health care, helping employers take charge of their health plan expenses, and helping physicians and other practitioners take charge of their healthcare careers. Learn more about the HELPcare Clinic difference at helpcare.health.